Hello, this is Beth Friedman, Senior Partner at FinPartners. I'm based in Atlanta, and today we are talking about the Data Humanity Lab. I'm Beth Friedman.
I'm Joe Foster.
And this
is Fin Voices.
Today on Fin Voices, we talk with Brian Urban, Director of Innovation and Emerging Markets at FinThrive. FinThrive is an end-to-end revenue cycle management company. Brian has experience in health promotion and product development. He holds an MBA, and he's actually currently pursuing post-grad studies at Brown University, focused on emerging technologies in healthcare, something we all certainly are studying these days in one way or another. Our conversation is going to explore a joint research venture that began as an idea at Unica University in 2022. After winning a grant from Robert Wood Johnson's Health Data for Action program, the idea became a full-fledged initiative. It's the Data Humanity Lab, and that's our topic for today. Brian's been a driving force behind the lab since its inception. So Brian, welcome to the show.
Thank you, Beth, for having me. This is a true pleasure and honor. I'm excited to talk about the Data Humanity Lab, its creation, and the impact we hope it'll have.
Super. Let's get right into it. So I didn't do much of a history except to talk about some of the original partners, which FinThrive, of course, was one. So can you go ahead and just give us a brief history about the Data Humanity Lab? Tell us where the program started and where it is today.
Yes, such a honor to be, I'd say, the league architect behind the Data Humanity Lab, but a tremendous amount of support in creating this project and building it into life right now. So I have to shout out to our VP of Innovation, Sam Perret, Chief Innovation Officer, John Yount, CEO, Heyman Goyal, and our partnership with TransUnion Healthcare as well in this, and so many others, Jeff Becker, Brenda Reed, Pedro Basio. There's so many, the list can just keep going on and on, but I'm very thankful to be the voice of it and maybe the heartbeat of it. So the Data Humanity Lab, I love the name. The name is very unique to what it represents. So to define it, it is, for me, a wrecking ball of learning and giving relative to socioeconomic data, and that at the individual identified level, household and community, and aggregate upwards as well. And our goal with the lab is to help improve existing health equity projects or programs within healthcare, health plans in the U.S., to really take them to the next level and into a better alternative data set that sits outside a traditional healthcare view. And the other side of it is the learning lab. Really, it's an opportunity for us to see what the unique use cases are for alternative data sets that are not claims, that are not charge master data relative to point in care, point in time kind of capture or screenings as well. And it's really to just say, hey, to the industry, here's how you can start to think about using socioeconomic data that will incorporate the way that you get measured in payment in terms of healthcare delivery, and how you can go upstream and actually identifying people's needs that are directly connected to how they access healthcare, or maybe don't, or don't trust, or don't want to engage, how that can play a much better journey downstream for an individual, family, household. So it's been around for, the idea has been around for 2 years, and we're really alive for almost a year now. But I'll pause there. That's just kind of where it came from. And I'd say maybe one last part there, Beth, is no one in terms of privatized entities like a credit bureau or like a RevCycle or a data stack company has ever done this pioneering event of giving away data for no cost and also giving services with it, and then putting on a beautiful storytelling opportunity to help others do the same thing. So it's really our kind of wrecking ball I go back to is making others do this as well, and doing it in a very loving, aggressive way. Because if we don't have other data entities contributing data like this, then they need to rethink why they're maybe in the healthcare industry in the first place.
Exactly. A couple things, having been in the industry myself for a long time, that really stood out from what you just said is data. So the past year, two, three, I keep hearing over and over again in healthcare that data is the new currency. So absolutely reinforcing that. The second thing you talked about is using the data across the ecosystem. So you mentioned health systems and payers, to number one, contribute or help support them in their new regulatory requirements. Like I know, is that the health plans and payers now have the health equity index, correct?
Mhm.
Where they had, that's how their star ratings are going to be calculated. And actually 24 is the year they're going to start looking at that data. So real important for payers and plans. But then you also mentioned for providers, right? Where do they put their programs in the community? Where do they need to do the outreach to improve wellness and outcomes? So it's kind of firing on all levels. It's pretty exciting.
Indeed. Indeed. Yeah. And I love what you mentioned there. The health equity index as a part of the stars ratings is going to be a huge impact. I believe, capturing it through 24 and 25, and then the year of 2027, and then payment year of 28 is where we'll really feel the impact. And I looked at a lot of how Medicare Advantage organizations are being directed and guided with one of the final rules from CMS. And for me, it's a great push forward, but it seems like it's very dependent on putting the SDOH risk assessment into play, which is great. However, it's a point of information that you're capturing at a point in time. And if you've never seen the SDOH risk assessment, I see it with my children in pediatric appointments. It's not the way to do this. It's not a humanistic, loving, intuitive approach. It's on paper, or even if you want to do a digital survey, I believe there's modalities that exist there. But if we can actually pull together data that would prioritize these questions and help the physician have a conversation, not a survey, that's where healthcare needs to go. And I'm hoping this program will kind of push it that way. Surveys are great, but at the end of the day, it's not where we need to be. So I love what you're saying too, Beth. I mean, we're on the same page. It's really an exciting time right now. It just kind of happened to line up that way.
And I love what you just said, Brian, about the data. We've been capturing it in healthcare for a long, long time, right? But are we really doing it the right way, right? So that's what
Yeah.
it sounds like is an important point to put out there. Let me ask you another question. Let's talking about healthcare and data generally, and then sort of specifically the socioeconomic and financial data that you guys are working with. So your project kind of goes way beyond that data we get out of the traditional claims, which are typically 30, 60, 90 days old. Your program actually, to your point, right, is alive.
Yeah.
It's week to week picture of the patients, the members, residents in the community. So
Mhm.
it's data that really can be used dynamically for those conversations.
Yeah, it really is. And to kind of break down the data that we're deploying in these donations and really accelerating programs that exist today, it's getting the real goodness of TransUnion Healthcare into the view of research, and that being at the individual level, coming from three big buckets of data: kind of consumer marketing view, adverse life view, and then an economic stability view. And all those together is more of a holistic picture of what's challenging an individual day to day: job loss, a loss of a loved one, change of address, addition of phone, loneliness indicator, close to kin, or even those that live within the home, and their economic status. What are they making, or what are they late on in terms of payments? There's such a very rich view that if you know it to a high degree of certainty at the right point in time, and then you continue to follow that attribute set of data, it shows the real journey that's stacked on top of why is someone not coming in for their OBGYN appointment and they're now 6 months pregnant, or why is someone having lean judgment criminal activities related to hey, they're coming in the ER to get more primary care. There's so many scenarios in which this can showcase what's happening for someone. And to make it real, our first really exciting data donation is with Christus Health in Texas. They're Christian-based mission healthcare system that has many, many lives inside Texas, but then also in bordering states. And that first project, Beth, is just so exciting. It's 20,000 patients that we're looking at, and we're seeing these folks from a perspective of how can we help them avoid 90-day post-late payments for healthcare services that were rendered for them, many months ago, and how can we help the healthcare system avoid bad debt? How can we change the whole billing collections write-off process, not using existing data inside a healthcare system's walls? And this is really a health equity approach, looking at what people are challenged with and how can we change the whole billing collection space. So for me, selfishly, I'd like to wipe collections agents off of the planet, shift their talent into something more helpful that is way upstream, not to, take people's jobs away, but just completely shift what they're doing into a different model. And that's just going to change how healthcare is seen. You talked about currency, trust as currency for patients and providers, especially those of lower socioeconomic means. That's a very difficult thing. You can't just buy that as a healthcare system. You got to earn that, speak the language, be culturally competent, be very thoughtful in your bedside manner. So there's so many cool things I want to talk about with that project, but
Yeah.
yeah.
Well, I think what you're touching on then, Brian, is what I call Maslow's hierarchy of needs, right? It's like, nobody's going to care about a follow-up OB visit because we know post-maternal health is really poor, right? Those moms that are really the vulnerable ones, right? And in a difficult financial situation, they'll forego their post-maternity visit to put food on the table, right? And bottle in the baby's mouth. I mean, it's just natural and it's human. And so being able to take up-to-date socioeconomic and financial data I would say to inform our social workers, our caregivers, our clinicians to paint that bigger picture of that patient as they walk in the door or as they don't walk in the door, to your point. That's going to be so helpful in healthcare.
Yeah, it really is. It's going to be fascinating as we kick off this project. The first one that I mentioned with Christus Health coming in June 2024. It's, we're right on the verge of starting, and it's just going to be so insightful to open up a healthcare systems data billing collections team to a completely different view of the lives that they're serving. So it's going to be really cool.
That's super exciting. And I know I'm looking forward to this in about a month. I will see you speaking on this topic at the HFMA conference in Las Vegas with Christus. So I'm actually very much looking forward to the full presentation and then following up with you afterwards as well.
Yeah, it's going to be, thank you for that plug. I appreciate it, Beth. It's going to be so cool. We're fortunate to have the VP of Patient Access, Ryan Riddle, joining me on stage to talk about our adventure we're taking over the next 12 months here with 20,000 patients, using a very sophisticated approach in terms of how are we going to change billing collections processes relative to populations that have historically and even generationally had accumulated medical debt to the point where their trust is eroding and their engagement is a far reach. And my hope is that we just get others in the room to be very inquisitive of what they can do. Hopefully we get a lot of questions and curiosity and even maybe some challenges of how we can do this really, really well. And others, hopefully, we have our partners and our competitors in the room and they pay attention to this. I'm going to take a locker room approach and have everyone get really passionate about doing better, what they can give to, and then questioning if they're not thinking about this. My message may not hit executives of this time's ears, but those of a future executive caliber, what are they going to contribute to the ecosystem? Otherwise, I highly suggest that they go into a different industry, go into banking, go to
Yeah, right.
retail, go just
Okay.
get out of here, make room for others that want to make a real difference and a real change. So I'll say that in the nicest way I can, but it's still going to be a fun conversation.
Yeah, absolutely. I look forward to it. Um, Talking about that. So let's talk about this. I started as a medical record coder uh, before DRG, so that is really dating myself. So it's been a while, right? And I worked in a hospital for a little bit over a decade. And in that role, I was very ingrained in the revenue cycle. And a lot of my colleagues working in the hospital system were similar. They've been there for years. They've been doing the job for years. I think a lot of times, and I think it's still true. I'm hoping maybe you'll tell me it's evolving, but in the revenue cycle in healthcare, there are a lot of these sort of traditional mindsets. We've always done it this way. That's kind of plagued us for many, many years. So I guess my question is, number one, is it still that way? And then the second question, what we're going to be doing is asking these revenue cycle teams, to your point, think a lot more holistically. So it's not just a bill, it's not just a late payment, it's not just a failed to pay or whatever they would term a delinquent account. It's an actual human with human
Yeah.
problems. So paint some scenarios of how we could maybe help these legacy revenue cycle teams make that shift.
Yeah, I love this question. I'll answer it in a couple ways, and I'll try and stay on point to your question. So, what I do find interesting is from a report that we had just done with HFMA, a great research project relative to EHR integration, and coming from the revenue cycle management approach, where I think we're starting to see a change is the back end analytics and some of the front end virtual intake. So not maybe too much on the mid revenue cycle part, but the way that we're starting to identify people through socioeconomic, financial aggregated credit data is really, it's starting to hit up front. And I think Epic, they will continue to lead the way in innovation and in volume because they have a big market share. And I think they're influential for others like a Cerner, Meditech, and other smaller EHR vendors. And then the back-end analytics, I think, is going to be where a lot of investment is going for how we're seeing the flow of money relative to the challenges of the populations being served, and how is that being presented in an actionable way to end users, like a licensed clinical social worker, like a mid-level, high-level practicing physician that can actually do something. So then the impact is made downstream or right-sizing healthcare at the end of the day. We're starting to see that from really cool research that we had done with HFMA, and we're going to put that report out. It's about a 20-page report. It's qualitative research that my team, Praveen Reddy, great researcher, has been leading. He's a PhD candidate in his world outside FinThrive too. And I think that's where we're starting to go. I think the biggest challenge is we're still working in the mindset of the terminologies that you just opened your question with, which is late payment, delinquent. Like we're thinking in these very old white guy financial terms from the early 1900s that have taken us all the way to date. There is no human pulse connected to those terms. And quite frankly, it's something that I hope expires. Right now, credit bureaus still run the world of how lending, buying power is achieved at the individual and family level. And if we start to actually think about it in a different way, the population in the US, 330 million roughly. Of that, we have a lot of veterans, as a good example, that are of homeless nature, of high social health needs. The VHA can't do everything on their end. There still needs to be private investment in our ecosystem. And then you think about those on CHIP, Children's Health Insurance Plan, those on public insurance. We're talking tens and tens of millions, and the public health emergency unwinding that was kind of redetermining people's eligibility that hadn't happened in 3 years through the pandemic happened. People fell off, and then they still needed help financially. So I guess where I'm going with this is if we get rid of these terms and think about the human need, everyone will get paid at the end of the day. It's cool. You'll get your money. But if we don't do this right, we're not going to feed the middle of our economy. We're not going to help bring the bottom up. If we keep judging and not using our data for something helpful to make economic shifts in the industry of healthcare, in the industries of population health, community health, even tech enablement. So going way off your question there, I think the industry is changing in terms of our tech and those that are working with finance and healthcare. But I think the industry at large is still stuck in this very old view of, hey, you didn't pay. Hey, you didn't pay. Like, come on, where's a reason for the underlying why? And if you have visibility to it, I suggest you help. Or like I was mentioning, go into a different industry.
Exactly. I love how you said, like, bring the bottom up. There's a book. I had the chance at one point, we're going to go off a little tangent here, Brian. I had the chance at one point in my life to meet the then president of Liberia. Yeah, like the poorest country in the world in Africa, in West Africa. And I asked her what her favorite book was, and she said The Bottom Billion. How do we bring that bottom billion up?
Wow.
And that was from a population perspective, but I hear what you're saying too.
Yeah. Wow. That's a really cool tidbit, Beth. There, Sierra Leone, they see so much spillover in terms of virology and infectious disease. And it's because of poverty, access to healthcare as well, clean water, food, it's everything. But wow.
Yeah. I'm working with a nonprofit here in Atlanta that just is getting ready to open a mom baby hospital in Liberia. But that's a topic for a whole nother podcast. I'll have them on next. All right, let's take a quick station break. You're listening to Fin Voices. If you're enjoying the show, consider subscribing on Apple Podcast or wherever you listen to your favorite podcasts.
In healthcare, trust is everything. That's why leading health systems turn to FinThrive. FinThrive delivers proven healthcare revenue management based on decades of experience and a relentless commitment to innovation. FinThrive ensures healthcare systems thrive with profitable, compliant, and accurate revenue cycle solutions. From insurance discovery to claims management, FinThrive brings efficiency and reliability where it matters the most. Join the ranks of forward-thinking healthcare leaders who trust FinThrive at finthrive.com.
This is Beth Friedman with Fin Voices. We're back with Brian Urban, Director of Innovation and Emerging Markets at FinThrive. And we're talking about data for humanity. Specifically, how to use new capabilities and data sets to address some of the health inequities we see here in the United States. Welcome back. So, Brian, I have a question. We talked about the mindsets of the people in the healthcare ecosystem and how some of that needs to shift. I totally agree with you, on the same page there. Let's talk about, and you already mentioned Christus.
Yes.
Can you give us a little bit more detail? Like what you mentioned, 20,000 patients this year, 2024 is when the project will launch. What are they hoping to get out of it? Like, what is Christus really hoping to do with the insights that they will glean from this expanded data set?
Yeah, the overarching view and I'll say advisement of where this project sits is actually within HFMA's Health Equity Billing Practice Project, that they have 13 different healthcare systems. Some are of an integrated delivery network, some are standalone. And they approached us and said, hey, you're launching this Data Humanity Lab project. Can we be a part of it? Can we recommend healthcare systems that are trying to do upstream change in their billing collections to have better engagement, better healthcare utilization in terms of outcomes, and then also how can we kind of start to eliminate bad debt as well from an economic view onto the healthcare system side. And Christus came to the top of the list. And with that said, these 20,000 lives we're looking at is going to look at the beginning of July 2023 all the way through most of 2024. So it's part retro, catching up into more real time to show a journey of the majority of these 20,000 patients having matured medical debt to the point of write-off, to the point of creating some big challenges from a balance sheet perspective for a healthcare system. And how can we resolve this? So the first pool of this data will look at about 8 data attributes showing everything from loneliness indication, which is a proprietary algorithm that TransUnion Healthcare has developed. And it really looks at who's living with the individual, transportation access, close to kin, that's relative to their resident geography that we've identified at a one-to-one match level. And then the other adverse life events I was mentioning earlier in the show here, which is job loss within the last 12 months, dispersion of phone, which is different phones associated, moves. Those are all indicators of economic distress or challenges someone's facing that is directly connected, again, to healthcare utilization, healthcare spend, healthcare trust. And looking at this more holistic view, I think from our first data pool in June all the way into the next data pool and analysis we'll do toward October of this year, we'll really look at like, wow, what has the journey been for these lives? And where, as a healthcare system, could Christus have intervened earlier, knowing things that are not captured traditionally in a medical record or SOAP notes from a physician, or really authentically captured in follow-up surveys. So that's going to be the really cool view. And the end of this study is the hopeful product and dissemination plan we'll be carrying through is a best practice guide for other healthcare systems to adopt alternative data sets that best suit the populations they're looking at to best address medical debt for patients and then bad debt write-off scenarios for them as a healthcare business. So that's going to be the really cool view of, hey, here's what we found. Here's the most helpful data attributes. Here's the approach taken in an intervention and engagement, because we're going to work through that with Christus. And here's our best recommendations for you, other healthcare systems, to adopt and start to change your billing, collections, bad debt write-off processes that take things way upstream and help people. And most likely you'll see a return on healthcare utilization, healthcare outcomes, and how that might even change your payer relations as well, and contracting. And aside from the engagement with patients and populations that you serve in one state or one geography.
Let me paint a what if. Like, what if like there's certain diagnoses that we know you're probably going to lose your job because you just aren't going to be able to work, right?
Yep.
So let's use one of the nation's top one, stroke. So stroke patients probably are not going to be able to work. They're probably going to lose their job. So like being able to catch that right at time of diagnosis and start, paving a better path for this patient's financial journey, whatever that might look like, knowing that they're probably not going to be able to work. Right.
Yeah.
Something like that. That sounds so exciting. And it's kind of why we're here, right? We're not just, thinking at the patient's health journey or care journey now. We're looking at the financial journey.
Yeah, we really are. And in the US, healthcare is such a innovation, a gap in access, in a business, first and foremost. If we push a little bit more and lean a little bit more onto the fact that it is a business, we can't rewrite all the rules at once or even within the next decade, then what we can do is start to make better business sense for the lives getting healthcare treatment and for the organizations that are rendering those services, delivering those services. And if we can do that through alternative data, then we'll be one step closer to having more of a value-driven ecosystem in healthcare rather than how it's kind of malfunctioning in parts today.
And, I would say even at the end of the day, over the next 5-10 years, to be able to build back that trust. I feel like we've lost trust in healthcare with our patients and our members, if you're a plan. Yeah. So I've got 2 more questions and then we'll wrap up. FinThrive. FinThrive is a revenue cycle management company. You've got strong legacy, strong backbone in advancing the business of healthcare, and really hospitals, health systems. That's where you guys focus. That's where you deliver most of your services. But it sounds like an emerging side of FinThrive might be looking at places where some of this care is delivered for these underserved populations, FQHCs, health plans, how we can even inform life sciences and tech startups. Can you give us like maybe an example of what FinThrive's looking at progressively in some of these areas?
This is great. And this is the future of what a revenue cycle management, I'll say maybe a very athletic minded, agile revenue cycle management firm is looking to become. Obviously, our bread and butter is our revenue management stack. That's claims, contract modeling, RPA on top of remittance processes. So it's everything from getting things paid to uncovering what insurances people have at the individual level and kind of right sizing the economics between a payer and provider. Like that is how we do business. But the next big steps in how we grow into the emerging market space, to your point, listing those different organizations, is through our unique data. And I'd say a big set of it is our real world evidence data, our charge master data, the relationships we have with healthcare systems and hospitals, and how we package data to life science organizations that are trying to make next generation device relative to cancer detections, to condition management, and then also clinical research organizations, healthcare tech startups that are social health in nature. I think Papa is a great example. Upside for housing, Laguna Health is a good example. Telehealth companies like Teladoc, Spring Health, mental health. There's over 100, I think, organizations right now that are mental health, and there's like 20,000 apps. So it's a huge space to help and help make the impact in the most appropriate way for the individuals being served. That's where we're going. And I think as a revenue cycle management company at our heart, if you stack those unique data insights on top of what we're good at already, we go beyond the finance of healthcare and we go into how we're recreating as architects the healthcare journey of populations across the US, and only impactful data that is showing individual, like real-time information is going to do that. And it's not a laundry list of thousands of attributes, which we could easily do, but it's the right stuff for the right types of providers, the right populations, and how that's going to stack on top of the finance side that we're so good at. So that's the next big step. I can list out so many other organizations that we're working with, but it's exciting to see some of this stuff come to life. It's a ton of work. It's not something that we have a big foot in those markets, but it's somewhere where we're going, and we're leading with authentic curiosity. And quite honestly, for me, a lot of it's kind of business sense love. Everyone sells in a transactional nature, but if we can layer on top really cool philanthropic innovations like Data Humanity Lab, that changes how we're seen, and that changes how our partnerships work. And it's less transactional. It's more like, how can we obviously help the people we want to help? So that's the real cool part that we're trying to advance in a creative way.
You know, Brian, I love how you described all that. And my brain always goes to like an analogy or a word picture, right? So I was just in Florida this week, and I was next to the highway. It was a high-speed train. They have a high-speed train now from Orlando to Miami, I think.
Yeah, I did see that, yeah.
I don't remember the name of it, but it's pretty impressive when you see it. I mean, this thing flies.
Like light
So
rail,
like,
something like that?
maybe, I don't know.
Like that?
But
Yeah.
but I'm thinking about the data we've been talking about. Maybe even going beyond data as currency. Maybe data is the rails, right?
Yeah.
That's going to support that train. And FinThrive is like, you guys are pushing it forward. You guys are the train. You know, you're going forward as fast as possible to get healthcare as an industry, and especially, you know, the sort of stodgy revenue cycle financial side of healthcare, get us way into the future where we need to be.
Yeah. Yeah. I love the analogy you just shared, Beth. I feel just this immense amount of not bad stress, but good stress to make this work. Because if we can make this type of approach work, the Humanity Lab and beyond, then it will absolutely influence other organizations, competitors alike, or partners to do something similar in their own way. And man, that multiplying effect is just like the utopic vision I have in my little brain, and I hope it happens.
I do too. It sounds amazing. So, your first stop of your train is going to be your presentation with Christus at HFMA in June in Vegas. I will see you there. I look forward to reporting on that in my wrap-up article from the event. And then who knows where the train's going to go, right? Let's talk again sometimes at the end of the year or next year to see where we end up.
Thank you, Beth, for giving us the stage here on your podcast. The Humanity Lab is, I think, a shining beacon, not only for the brand of FinThrive, but for the philosophy of how we can advance the healthcare economy. And I'm really excited for others to be curious about this, to push us, to test us, and for them, in terms of other companies, to adopt something similar in nature and make their own impact. So really excited, and I'm looking forward to seeing you in Las Vegas.
Absolutely. Thank you for being on the show. For the listeners, you can reach Brian on LinkedIn and learn more about the Data Humanity Lab at FinThrive. That's FinThrive.com.